extraction and replacement. Okay. We will discuss about the general principles which we use for replacing the lower anteriors, especially post-extraction cases. Okay. So the first thing is how many tooth we are going to replace and what is the mesodistal space available. That is also you need to consider, because here it looks as though we are going to replace 4 incisors, but they are little proclined and light crowding is there, but the mesodistal space won't be enough for the exact 4 incisors. You may have to give a smaller size 4 incisors or bigger size 3 incisors. The same challenge we will expect when there is too much of crowding. There will be 4 incisors, but they will be crowded to each other. But post extraction you can place only 3 incisors. So in that case, after extraction of lower anterior, how many implants we need to place, it does not depend on how many teeth you are extracting. It depends on how much of mesodistal bone is available between the adjacent teeth, both at the crestal level and the apical level also. Why apical level is important? Because the adjacent root may tilt mesially, okay, reducing the space for placing implant. So how many implant we have to place depends not on the number of tooth we are extracting or we are replacing. It depends on the mesodistal space. For example, if the patient is having a very U-shaped arch, the mesodistal space will be very good. But if the patient is having a oval arch or especially V-shaped arch, you may be extracting 4 inches, but the mesodistal space available will be less. Okay. So don't judge the number of implants by seeing the clinical picture or the number of teeth you are going to replace by seeing the X-ray. Okay. So most commonly, if you are extracting 1 incisor, 1 implant, 2 incisors, 1 implant, you can give 1 tooth as cantilever. If you place 2 implants for 2 incisors, then implants will be close to each other. The implants will be close to the natural tooth. If you are lucky, it may give no trouble, but otherwise you may get trouble. No? Both the implants will fail. If you are extracting 3 incisors, definitely it is 2 implants only. Don't put 3 implants. Okay. Placing 2 implants will reduce the implant distance, bone loss, all sort of problem. Or if the implants are touching each other in the bone level, patient will have pain, constant nagging pain. So 3 incisors, 2 implants. If you are replacing 4 incisors, also 2 implants will be enough most of the situation. If the space is very wide, then you can think about placing 3 implants. So 4 incisors also 2 implants. So 4 incisors, 2 implant is a risky situation actually. Both implants should be, you should get good stability. If you get good stability of 1 implant and if you don't get good stability of another implant, then the entire process is risking failure. If you are placing 3 implants, then the risk is less actually. Even if you don't get good stability of 1 implant, the other 2 implants, they may give success. So 4 incisors, 2 implants is a tricky situation. You have to achieve good stability for both implants. If canine to canine goes for extraction, you can plan for 3 or 4 implant. Okay. But most commonly 4 incisors is the situations we see in the practice. When we remove canine to canine, many times canine will be good, but still sometimes we tell patient to remove canine to canine. When?
Proclination, deep.
Yes. In 2 kind of situation, when upper anterior also we are replacing. Upper anterior canine to canine we are replacing. The lower canine, if occlusion is buccal and more superior, like in debate cases. Or if you are doing upper full mouth, you are doing lower anterior only, the premolars and molars are good, then you have to remove canine, because most of the time the canine is outward and upward. Here also you can see the canine is it is okay. Okay. So the planning is very simple. Only 2 implants. Definitely 1 implant on the one end and the other implant on the other end. So we have to decide certain things. The first thing is what design. Location is very simple. There is no difficulty in location. We have to decide whether it is a basal or compressive. Second decision is diameter and length. And also angulation. Whether you are going to place axial or distal. Definitely not mesial, not medial, distal. So first decision is, what is the first decision?
Location.
No, location is already, it's simple here. There is no need for planning for location.
Basal or compressive.
Basal or compressive. So first we will see the 4-1 area. Sorry, 4-2 area. Okay. So whether to choose basal or compressive decides on certain factor. For meat extraction cases, what I am telling is, if there is no labial plate, but lingual plate is good, okay, then you can go for basal, because if you put compressive, the threads will be exposed labially. See, in this situation, if you do alveoplasty till here, right, where I am showing the mark, if you do alveoplasty till here, then you can place compressive also. But can you do alveoplasty till that height? If you do alveoplasty till that height, the adjacent canine bone will get compromised, right? So there is a limit to the alveoplasty we are doing. If you are doing full mouth, there is no limit. You can do alveoplasty till the apex also. But if you are doing alveoplasty for partial extraction cases, you cannot do without any planning, because adjacent tooth will be having bone. You may be removing the adjacent tooth bone. So there is a limit to the alveoplasty we are doing here. So if you see clinical picture, there is gum recession, there is enough prosthetic space, there is no need to open the flap also. Even if you open the flap, there is no need to do the alveoplasty. So I saw the clinical picture for this patient. The prosthetic space is quite decent, there is no need to do alveoplasty. When there is no need to do alveoplasty, there is no need to open the flap. Okay. Of course, if you want to see the buccal and lingual bone for access visibility, if you want to open the flap, that is okay. But for the sake of doing alveoplasty, there is no need. Clinical picture is there. So prosthetics, even if you give processes the same height, we cannot give, right? It is in the debate position. So we have to give 1 mm below the existing incisal position. Even then, there is enough prosthetic space. Okay, so there is no need for alveoplasty. This was I am telling. If you do alveoplasty beyond this segment, then the adjacent canine, that may get compromised. So we should not do alveoplasty here. Okay. Whenever you are planning for placing extraction and implant lower anterior without any alveoplasty, it is better to place a basal, because the labial thin bone, labially there may not be bone, right? If you place compressive, it may get exposed. Okay. So the first criteria in designing basal or compressive is presence of a labial bone or not. If the labial bone is not good or compromised, very thin, don't place compressive. So another criteria for selection is, what is the quality of the intramedullary bone here? Okay. If it is too cancellous, you cannot place a basal. You won't get stability, right? Only if the intramedullary bone is cortical, you will get stability. So for this patient, there is the intramedullary bone is good. So if you place basal implants, the basal design, it gets stability not only from this entire bone, it gets stability from the buccal and lingual plate. Okay. So this is around 3.1. If you place 3.6, it will get engagement from the. So the major stability in this situation comes from the buccolingual cortical engagement. Okay. So situation, if there is buccal bone is good, then you can place a compressive. If this part, the intramedullary part, is very much dense, like a D1 bone, then better to place a basal, because you cannot place a compressive. It may lead to failure. Okay. So these are all the factors. So one is the labial bone, and another one is the intramedullary bone quality. Okay. So what is the challenging situation? There is no labial bone, and the intramedullary bone is also cancellous. Okay. There is no labial bone, so you have to choose basal, but the intramedullary bone is cancellous. So this is a tricky situation. Okay. But here you can place a basal very comfortably. If you see the black space here, there is no need for the implant to go till here. It is unnecessary. Okay. So only you can stop short here. So this comes around 17 mm. Okay. Mostly the length will be around 14 to 70 mm. The basal design. It won't go up to 20, because there is no advantage in selecting a 20, because whether it is 17 or 20 or 14, the number of apical threads is the same. By increasing the length, you are increasing the shaft only. The length of the neck only you are increasing. So there is no obvious advantage when you increase the length. In case if you want to catch some good cortical bone, only if you select a longer number of implant, then you have to select that. But here, whether you put 14 or 17, it will be within this good bone. Actually selecting a longer length implant, it may compromise the stability. If 3 threads are in this cancellous bone, only 2 threads will be in good bone. So selecting a 20 is not a good idea. 14 or 17 will be enough most of the time. Okay. So if you place 3.6, exactly it will match this intramedullary bone shape. That means the blades will touch this labial and buccal plate. You will get good stability. If you are placing simpler dent, pilot drill and parallel drill. If you are placing byline, you may need to use 2.8 wider drill also. So we are planning for 3.2. Okay. We'll keep the implant away, we will see. Okay, so there is the intramedullary bone. Okay. This may be the intramedullary bone, or it may be the intramedullary bone with the associated canal, mandibular incisive canal. So whenever you see this kind of intramedullary radiolucency in the anterior region, there is no advantage in going through it, hitting that. What is the advantage? Your stability is not going to increase, actually it may decrease. Better keep the implant above this space. There are two advantages, because if you go till here, you may get stability problem, or not only that, the mandibular incisive canal, if it impinges, then it may give pain. And another thing is, if there is an artery vein structure is going, if it induces bleeding, then it may reduce, may lead to bone loss, periapical implantitis. apical implant rate, apical bone loss of implant will happen. There is one condition is that you will see bone loss surrounding the apex of the implant, because if you induce bleeding here, there is no way the bleeding is going to go away. Okay, the pressure increases there, it may resolve naturally without any trouble, or it may lead to, suppose if you are inducing some infection also during drilling and all, that infection may, the hematoma may get infected and it may lead to. There are many case reports in the literature where they are having a apical bone loss in the lower anterior region. The reason is this one, this kind of cancellous. If it is mere cancellous bone, that is okay. But if it is a mandibular incisive canal with the associated artery and vein, then it is not good. Okay. So choosing a shorter length, probably around 17 is okay. If you choose longer implant, you may even perforate here. Okay. So which we should avoid. Okay. See, if you see, this is almost like a C shape, right? C shape. Okay, this is C shape. If it is a full mouth, you will be doing alloplasty till here. Then it is no more a C shape. You can do the drilling straight. From here you can do the drilling straight. But now you cannot do the drilling like this. You have to do till along the apex only here. Okay, so if you drill in this angulation, definitely you will be reaching the lingual cortical plate. But after alveoloplasty, if you do drilling, it will go straight. So the risk of lingual perforation is more when you do only lower anterior cases. If you do full mouth with good alveoloplasty, there is no risk of lingual perforation because the drilling angulation is better now. Okay. But if you see between these two drilling, the abutment location is which is good. If you go along the apex, the abutment will come in correct position. But after alveoloplasty, if you drill, it will come very lingually. That is why in full mouth patients, they tell no, the lingually the process is bulky, patient having difficult problem because the alveolar bone loss happens, and we also do alveoloplasty. The moment the alveolar bone is not present, the drilling angulation, no, it changes, the abutment goes lingually. Then the prosthetic challenges will come. So the basal diameter is always 3.6. The length is almost always between 14 and 17. Very rarely it is maybe 20. That's it.